Hello, we'll make a start now. Apologies for the late start of this meeting. My name is Susan van de Ven, and I'm the chair of this meeting today. I would like to begin by welcoming those members of the public and press who are watching the live stream of this meeting via Cambridgeshire County Council's website. There's always a risk that we may run into technical problems, and I would ask for your patience if we do so. Should this occur, I will declare an adjournment while the fault is addressed and the public broadcast will be paused. If it is not possible to address the fault, the meeting may be abandoned until such time as it can be reconvened. Can I remind members and officers that all hybrid meetings are being recorded and that the recording of this meeting will be published on Cambridgeshire County Council's website. I will begin by calling the names of all members of the board to establish your presence for the record. Councillor Fitzgerald.
Yes, I'm here, thank you.
Nice to see you. Councillor Handley.
I'm present, Chair.
Thank you. Councillor Howitt.
Present and good morning.
Good morning. Councillor Walsh.
Yes, good morning.
Good morning. Jyoti Atri.
Good morning.
Gary Howsam.
Gary sends his apologies.
Apologies, thank you. Louis Campher.
Apologies as well.
Apologies. Jan Thomas.
Here apologising for everybody else.
A couple more for you. Stuart Francis from Health Watch, I think, has sent apologies, unless he may join online. We'll see. And Daryl Preston, I think, has sent apologies. And myself, Councillor van de Ven. We've also received apologies from Paul Fox and Joanne Proctor. Does anyone wish to declare a disclosable pecuniary interest or non-statutory disclosable interest? No. Thank you. We are being asked to approve the notes of the meeting on 21 January 2022 as a correct record. Can I ask if anyone who does not agree with this proposal use the raised hand function or raise their hand now? I see no objections to the proposal to approve the notes as a correct record, so we will take that as carried. There are two actions identified in the notes on pages 4 and 6. Jan, are you able to provide an update? This is pages 4 and 6 in the notes, and I'll just
Apologies,
don't worry.
My mistake.
No.
There's
no
outstanding actions.
No outstanding, they've been resolved.
Yes.
Okay,
Sorry about
beg your
that.
pardon, no problem. There's a lot happening day by day. You're off the hook, Jan. Great, okay. In that case, we'll move on to the next item, which is the update on epidemiology. Can I invite Jyoti Atri, the Director of Public Health, to provide the board with an update on epidemiology? Over to you, Jyoti.
Sure. So, just moving things around a bit. Can we get rid of the black box? Yep. No, if you press the button. Has that got rid of? Great. Okay. Thank you very much. So I'll start by describing the national picture. I'm afraid it's not the good news I would have liked to have shared with you. Deaths have been increasing nationally from COVID, so that's deaths post 28 days of a positive test. And the number of admissions has gone up dramatically, as you can see. The data that we've previously been sharing with you to indicate prevalence is no longer robust enough really to continue to share with you, because there's been a dramatic decline in testing uptake, and therefore we're not picking up as much prevalence as there is in the community, because testing has declined. And instead we are using the COVID infection survey conducted by ONS, which is based on a random sample of the population who are PCR tested. The downside of this data is that it's not as timely as the testing data that I've previously shared with you. So this data comes from the end of, the 12th of March. What we can see here is quite a bit of regional variation in prevalence, and in the east of England you can see that rates have been increasing but look like they're plateauing at the moment. There are increases to be seen in almost all of the other regions, as you can see from this set of graphs. We're currently estimated to have a prevalence across the east of England of 5%, which is historically comparatively high, and we are seeing widespread community transmission having an impact on schools and hospitals, as you'll see as I progress through this presentation. If we look at breakdowns by age, the sharpest current increases in the primary school age population, but we are also seeing increases in the working age population, and more worryingly an increase in the over 70s, and we haven't seen that for some time. And that's probably part of the reason we're seeing increased admissions to hospitals. Vaccine waning is an issue of concern in that population, who were at the beginning of the booster campaign, and so that may be partly why we're seeing an increase in that age group too. This is showing the number of PCR tests conducted, and as I said to you earlier, you can see that steep decline in the number of tests conducted. That's the grey bars on these graphs. The blue line are the proportion of those tests that test positive, and you can see that that is increasing as more latterly the uptake of PCR tests is also increasing, indicative of more circulating virus and more symptomatic disease. Also possibly behind this is the reduced availability of LFTs as we head towards the 1st of April. This is showing hospital admissions, and you can see that they have been increasing in all of our trusts. We now have, based on this data, 220, and Jan may have an update on that figure to give when I've ended the presentation. Most of this is incidental, so people going in for other reasons but then testing positive for COVID. But we are also seeing an increase in those who are being admitted because of their COVID, and even that incidental admission causes pressure on their health service because extra precautions need to be taken to prevent onward transmission. Deaths, reassuringly, are remaining pretty low and stable. There have been 6 deaths in Cambridgeshire within 28 days of a positive test, and 1 in Peterborough in the last 7 days after a positive test. Sorry, in the last 7 days within 28 days of a positive test. Did that make sense? It did. Good. This is showing the number of deaths more directly because of COVID, so they have COVID recorded on the death certificate, and that is also remaining pretty low and stable. These graphs are showing the uptake of the school-aged vaccination programme, and we are continuing to see slow and steady increase in the 12 to 15-year-old first dose. The second dose is obviously dependent on people having received their first dose within enough time for the second dose to be given. Cambridgeshire doesn't lag behind, particularly here, but Peterborough continues to lag behind both first and second dose. This is showing all-age booster uptake, and again, we are seeing a slow and steady increase in the booster uptake, and I think that demonstrates that it's worth continuing to persevere with the vaccine hesitancy work. We are seeing slow but increasing rewards. However, Peterborough and Cambridgeshire continue to lag some distance behind the national average for the booster, sorry, this is the first dose actually, campaign. And I think the fact that we don't see that gap for school age vaccine in Cambridge, but we do for all ages, suggests to me that this is more of a denominator issue rather than a real uptake issue in Cambridge. So that's the end of the presentation. I think we had hoped that this could have been our last meeting when rates were going down, but given the current situation with rates high and looking like they're increasing, and the pressures that this is currently causing in our NHS and educational settings, means that I think we probably need to keep the door open for future meetings. I think the data that I've shared with you is suggesting that we're not seeing the level of impact, certainly on deaths or as severe infection. We're not seeing the level of hospitalisations that we've seen with previous waves. Where this is really having an impact is on business continuity issues, and that I think is now the focus of trying to control transmission, to keep education running, to keep the health service running and other essential services. Thank you.
Thank you very much, Jyoti. Would members of the board wishing to ask a question or make a comment please use the raised hand function at the right of your screen, or simply raise your hand if you're present. Thank you. Jan.
Can I just comment a little bit about what's happening in health at the moment? So on data from the close of yesterday, we were up to 232 patients in hospital again. That's 89 at Addenbrooke, 66 at Peterborough, 54 at Hinchinbrook, and then smaller numbers at Royal Papworth and CPFT. The reason I raise that is that I think we are concerned about the balance of risk here. So we are still under very tight infection prevention and control rules. We are also seeing, as Jyoti says, a lot of this is incidental findings of people being positive rather than admissions for COVID. So we have seen a complete change. So the numbers are high, which is affecting our productivity and our availability of things like beds. But we are now really working hard with both the regional and national team on that balance of risk between closing beds because of COVID and getting more productivity through on for things like the waiting lists. And so nothing really to report back on that, but I think it's just mindful of the debate that we are heading towards. But Jyotie's absolutely right, the problem still comes with staffing because we are isolating staff. We do have large numbers of staff again, and that is starting to peak. And as we are reporting anecdotally, not actually we haven't actually got much the data yet to pick this up, is that what we're seeing is for at least 2 or 3 days of that, people who were able to be positive and work from home are actually now having a couple of days where they're unable to be at home and work. So some of that's why the business continuity profile has changed a little bit, and that plays through particularly for our smaller areas like primary, our bigger areas but with smaller, more challenging resilience like primary care, where previously they could have diverted to the telephone and work from home. Now that's more tricky if they're not well enough to work, but that is for a very, very short amount of time. So we are still feeling the effects, but as I say this all in the context of balance of risk, and I think we need to be really mindful of that balance of risk now going forward.
Thank you. Councillor Walsh.
Thank you, Chair. Come back to me, please. Just on that, Jan, I'm very interested about that balance and risk that you were talking about. So just so it's clear in my mind, does that mean you're examining at a local level the possibility to abandon the testing of people going in hospital with COVID and just say, right, take it at face value, they've come in for what they've come in, we never used to test them for COVID, are we going to stop doing it now because that in turn puts tremendous pressure on the hospital?
We have strict guidelines that we are working to, and we work with our central national infection prevention and control team, and we are working within their guidelines. We are all having a debate about the benefits of closing beds and having less capacity and then having larger waiting lists. And I think, and this depends on the trajectory for people using intensive care and becoming sick and admitted with COVID rather than admitted because they're ill and then finding out they have COVID. And that's what we're exploring, but we will not be going out of the national guidance on this locally. But I think it's a debate that we are all having, which is, at what point do we have to, for example, maybe, say, for example, test on admission, but actually then 3 or 4 days in, repeat testing when people are in might be less of an issue. But again, that is not agreed. That is just what we're trying to work through, but we will wait on national guidance for that.
Thank you very much. Councillor Handley.
I didn't press it hard enough, sorry. Living with COVID, that's what we've been told we've got to do. And, we all go out on the high street, and there are very few people wearing masks now. There are very few people wearing masks on buses and trains. People are coughing and spluttering all over each other. People just think it's gone, it's no longer an issue. If I catch it, all it'll be is a bit of a sniffle and maybe a bit of a sore throat, and then it's gone. So what worries me is, you're saying that the rates are coming up, but what can we do? I mean, what can be done about it? It seems to me that, all restrictions have been lifted, the people are blasé, but you guys, the guys on the front line in the NHS, are really struggling. And, we can see, there are problems with, GPs. In my GP surgery, long waiting lists, and I know that's the same thing all over the place. I just don't know what do we do? That's my question, and I don't expect you can really give me an answer.
You've actually almost announced the next item on the agenda, which is living with COVID. So I wonder, Jyoti, if you'd like to take that question with the. Do you want to? As you like now, or when we get
the one thing that we can do is push vaccinations, and we've seen what's happened in Hong Kong in a population that's not got an effective vaccine and not had previous exposure. So we still do have pockets of low vaccine uptake, and I think that's one thing we should and are continuing to push. I think the issue of business continuity is an important one, and we have messaged our workplaces, and certainly for our own workforce, I'm recommending that we don't all come back to the offices, that we wear the face coverings whilst we're moving around, that we don't bring all teams back in, recognising that this is having a well-being impact on people who aren't, haven't seen their colleagues for some time. Certainly come into work, but don't bring your whole team in, because you risk a big proportion of them then being unable to work. As Jan said, it does cause illness, it does make you feel unwell and unable to work for 2 or 3 days at least for some people. So I think carrying on with our messaging and pushing more of the business, the economic argument and the business continuity argument with employers, as well as pushing forward on the vaccine uptake, they're the approaches that we're taking moving forward. And we won't have testing freely available after the 1st of April. So it's, I think there's a bit of a cultural shift needed. We'd got before COVID into a mode where we just all came in. You know, we had a sniffle, or we'll just take some paracetamol and come in. I think that we need to go back on that and not come in, and being able to work online has, for most people, will allow them to do that. So I think there's some cultural shifts needed. The messaging will carry on, and the push on the vaccine uptake will be the thrust of what we do moving forward.
Thank you very much. I think we will then move on to the next item, which is living with COVID. We've had a good introduction to that, but Jyoti, could I invite you to... I'm afraid you're also the next person. You're definitely the star of the show. We've got plans for beyond April 1st, after you're living with COVID. Okay. Do you want us to wait for a second? Do you want Matthew, we could ask Matthew Hall, who's here on the screen with us. Matthew, we're sure you're absolutely ready to start now, so we're going to ask you, please, to introduce the item 7, communication plan.
Okay, hi everyone, good morning. Over the period since the last meeting, we've continued to communicate with communities around COVID prevention and vaccine uptake, and that's included targeting vulnerable and hard to reach communities, supporting our education team, communicating with schools, but also working extensively across social media, but also with the mainstream media, including newspapers, radio, and also local TV news. However, in the last period, we've also seen a drop-off in comparison to the year before, particularly around engagement on social media around COVID prevention messages. So therefore, we've done a review of that, and we're now refreshing our approach ready for the 1st of April. So around COVID prevention, we're looking at refreshing our toolkits, our communication toolkits, which will also include a new animation, and the campaign will be called Stepping Back into Spring Safely. And it really sort of ties in the messages around living with COVID. One of the issues that we also face, of course, is that guidance from government won't be probably published until the 1st of April. So we've got to make sure that we're in step with that. So one of the key things is about sequencing what we say. So we're working thematically at the moment, but we'll be able to adapt as soon as that messaging comes out and work with our public health team. We're also using co-production techniques, or that's the plan moving forward with the vaccine uptake. And we've produced a plan and strategy with our community engagement team, and we're looking to use that to work with communities to make sure our messaging and our approaches really hit home on those that may be vaccine hesitant, particularly around those community champion local delivery plans. So that's kind of the sort of broad brush sort of approach that we're going to be taking. Happy to take any questions.
Thank you, Matthew. Are there any questions? I guess we're waiting with anticipation for April 1st. Yeah,
absolutely.
Okay. Thank you, Matthew. Okay, we will revert back to Jyoti's report on living with COVID.
Apologies. The government paper on living with COVID has 4 key elements to it. The first is around the removal of all mandatory restrictions in favour of encouraging safer behaviours, and I think that's kind of been lost a little bit. People have heard the mandatory restrictions have gone and have relaxed, but really strongly in that guidance is the encouraging of safer behaviours and trying to maintain those as far as possible. There's a section that's about protecting the vulnerable, and vaccination is the key component of that, but also supported by targeted testing, which is really to employ the use or inform the use of antiretrovirals for those who are particularly vulnerable. Then there's a section that's around maintaining resilience, so that's the ongoing surveillance, the nature of which will change and will be reduced, but there will still be some surveillance maintained, as well as the mass vaccination approaches that we've already been employing. And then there's finally a section that's on learning from the innovations that have already happened through COVID and securing the opportunities that have arisen because of COVID. Sorry, pressed the wrong button. So from the 24th of February, we saw some policy changes implemented, and they were the removal of people who contacts who test positive, or those who themselves, people who test positive or contacts who aren't vaccinated, to isolate, and for testing of those contacts who are vaccinated. So that has all gone, and therefore if you don't need to isolate, you no longer need to be supported in that isolation, so the support payments have also gone. We are no longer contact tracing, because there's no benefit, as people do not need to isolate. And the legal obligation for individuals to tell their employers that they have tested positive have all gone, as have the number 3 regulations. From the end of March, the main change is the availability of testing, both LFTs and PCRs. And the guidance to businesses will change. We're expecting some further policy announcements at the end of March to inform public messaging, workplace guidance, etc. And then at the end of March, the COVID certification and the COVID pass will also end. In terms of vaccination, there will be an over 75s campaign, as well as one for people who are immunocompromised, and that's addressing the vaccine waning issue that I had mentioned earlier. There will also be an offer of a dose to those children who are 5 to 11. That won't be actively pushed. It's an offer that people can take up should they wish to. But also important, as has been mentioned in the previous health and wellbeing meeting, is the childhood vaccination campaign, and making sure that we keep up that campaign and maximise uptake. Thank you.
Thank you very much, Jyoti. A question from Councillor Walsh.
Thank you, Chair. Just a question for Jyoti on what she has just presented. Did I hear correctly that the COVID certification will end? And if I did, how will that impact on our travelling ability and being able to sit in a cafe in warmer climes?
I think that it's ending here. You will have to follow the restrictions of any country that you are visiting, of course.
Yes, what I'm referring to is the fact that if you travel abroad, you need to show that vaccine certification on your
I think that
phone.
that might be addressed in the further guidance that's being issued at the end of March.
Thank you.
Thank you. Councillor Handley and then Councillor Howitt.
I may have missed it, but are there data that shows that the majority of people who are admitted to hospital with COVID symptoms are unvaccinated? Is that available? If it is, I haven't seen it myself.
There is some data available, but as more people are vaccinated, more people who go into hospital will be vaccinated. Does that make sense? It's a bit of a difficult concept to grasp, but as the majority of people are vaccinated, it does still cause illness in those who are vulnerable, and so therefore even those who are admitted are likely to have had 1 or 2 doses.
The point I'm getting at is one of the things that might persuade people who are with vaccine hesitancy is if you could say, if you go into hospital unvaccinated, you have, your likelihood of dying or being extremely ill is that compared to that if you are vaccinated. I I just wonder if that's an argument we can use.
Yes, and we have. So we've used that kind of data in campaigns, and we can share that with you after this meeting, yeah. Okay.
Councillor Howitt?
Yeah, almost everyone in hospital at one stage was unvaccinated, and it's a good point. 3 points from me. One, obviously, Jyoti's summarised national announcements, and we're a local outbreak engagement board, but I just put on record, I think it's regrettable that the testing is not going to be free in the future, and I think it's regrettable that the benefit support for people to isolate is withdrawn because poorer people in Cambridgeshire are less likely to be able to follow the voluntary guidance that we've heard from our Director of Public Health. And what we're really seeing here is a situation where there's a advice for us voluntarily to do things that some people can comply with and some can't because they just can't afford to. But the accountability for that is the central government. It's not with anybody in Cambridgeshire or Peterborough, but it should be said, rather than just sort of nodded through. Secondly, Jyoti made a similar presentation to the one that she's made today into our committee in Cambridgeshire County Council about a week ago, and we had a long discussion, and the outcome of that was that we very much strongly support continuation of the precautionary approach and the advice that she's given today, and that there are real risks in people feeling that the pandemic is over, and you know, let's use today just to reinforce that. And then the last point, you know, as we know, some of the infrastructure on the county council side as well as on the health side is being dismantled because we are going into a different phase, and it's good, you know, it's good that the discussions are going on and difficult choices being made, but it's right that we are moving into a different phase. But I think it's terribly important that we learn the lessons so that we feel that we've done service to preparedness for future outbreaks, future pandemics, whether it's COVID or anything else. And that's not about saying let's have our own local inquiry to everything that went wrong in COVID. That's taking place nationally. But it is saying that we have a responsibility both within our public health team and with our health partners to really say, are we better prepared next time? Because lots of experts say next time is not going to be 100 years' time, but it's going to be probably while it's still on our watch. So I'm very, very keen that we pursue that as well.
Thank you. Jyoti, did you want to respond?
Yeah, absolutely agree. We've done some internal reflection when I first arrived that we used to improve our own internal response. There's a session being prepared for Peterborough to reflect an internal one on our response. The CPLRF would be responsible for the system-wide reflection, so we can feed that into them. I'm sure it's on their agenda in any case. But yes, you're absolutely right. Undoubtedly there'll be things that we can do better, as well as preparing for a public inquiry. That's an important part of our kind of debriefing.
Thank you very much. And I think we, as you mentioned earlier, Jyoti, we had thought this might be the last meeting of this local outbreak engagement board, but it is not. And as we heard from Matthew, there's a lot of work coming up very shortly on communications and our messaging, and we'll look forward with anticipation to the comms team's work with guided by our public health team. So yeah.
Just wanted to make one more point about testing going. I think we have to be guided by the epidemiology, and we know that rates are high now, and people are thinking, I've got a cold. Actually, they've probably got COVID. So if we can put out messaging to say, if you've got symptoms, now, given that our rates are high, you've probably got COVID and should stay away from others. So we can use the EPI to inform our messaging as we move through this, and we won't have testing.
Okay, thank you very much. We do actually have item 6, which is called Plans for Beyond the 1st of April, which we've been discussing. Is there, Jyoti, this is your agenda item again?
So I think I've covered what we're planning to do in terms of messaging to the public. We, my team, have spent the last 2 years doing pretty much nothing but COVID, and that unfortunately has been to the detriment of the other important things that they need to do. In the Health and Wellbeing Board earlier, we heard about the impact that COVID has had on other risk factors, behavioural risk factors, obesity going up, alcohol consumption, etc. And they really do, after 2 years of not doing the day job, need to go back to focusing on that. So I have written to the UK HSA, whose whose predominant responsibility is health protection, to set out what I think is reasonable from my team. Past the 1st of April, I'm yet to hear back from them. We are keeping a small team as a contingency should we need to step up again and add extra resource if rates do go up dramatically, or if we have a new, more dangerous variant where we might need to return to some of the previous measures such as contact tracing and isolation. So I've kept that as contingency. That's paid for through CONF money, COVID Outbreak Management Fund, which only lasts next year. And I think there are further considerations and discussions happening at a national level about the role of local government in managing health protection issues, and how what will be the arrangements and how they'll be funded after next year. So there's nothing conclusive for me to report back to you, because no decisions have been reached, and the issue will be money. There will be no additional money for this. We've got a finite pot, and how that's distributed will be of concern. But I would be reluctant to take on additional pressures without appropriate funding, because that comes at a cost to the day job.
Thank you very much for that, that report. Are there any questions from members? No. Okay. Thank you. We will then move on to item 7, vaccination plans. Can I invite Matt Oliver, Head of Think Communities, to introduce this item, please?
You can, and I'm not sure if people can see me at all, but I can't see myself. So I am also sharing, I hope, a screen. So if somebody could let me know if they could see it, that would be helpful.
Yeah, we can see the screen.
Okay, brilliant, thank you. So I'll just use this slide just to help shape the things that I'm going to say. So we're moving into a new phase of the vaccine confidence programme. So very much the focus previously, of course, as is right, had been on ensuring that the mass vaccination programme had made sure that the majority of people have been given vaccinations or had the opportunity to have vaccinations, and we were working very, very closely at that time alongside the CCG and Public Health to ensure that we were building our local ways of being able to engage with people who may not want to take up vaccination. There's been a lot of learning over the last 18 months or so as we've been doing this, and we're now moving into a kind of more consistent delivery model alongside, as I said, the Public Health and CCG, which means that our outreach and hyperlocal evergreen offer for people who still haven't got a first or second vaccine will become more mainstreamed and will be kind of consistent and manageable as we move forward. So also the group have been developing local area profiles based on the data that we're now able to or where they have been able to draw together based on a number of different areas. So key geographies where vaccine uptake has been low, key ethnicities where we know that there's been less uptake of vaccine, key age groups and vulnerable groups. So we're developing a single forward plan of activity based on those profiles, but it's also informed individually by districts and by city around the things that they think are important and the individual data and the insights that we've got around those areas. So maximising the community engagement and aligning with the Mass Vax programme, including taking the opportunities where we've got boosters and to really do lots of communication as well around first and second vaccine, because we've seen that those increased when we had mass vax boosters or cohort boosters. So we continue with the creative and innovative ways of reaching key communities and cohorts. In Peterborough, we've got Vaccine Champions funding, and also in Cambridge City, they've got Vaccine Champions funding, and we continue to work with our other districts to make sure that they've got the resource in place to be able to join up the practical arrangements for communicating and engaging with local communities and cohorts, encouraging them to be able to access vaccine wherever they are, and working with our comms team to get the messaging right and to co-produce, as Matt said, those communication channels. So we're also doing a few other things, so aligning the resources that we've got with the enduring transmission and other health inequalities work, because it's not just COVID vaccination where we've seen a correlation between uptake. There's also other health inequalities work, and making sure that we take the opportunities to make every contact with our maybe lesser herd or vulnerable groups where we can, to encourage them to take up the vaccine. That's led to some resource alignment, which has been very, very helpful for the programme, alongside our public health colleagues, which is very, very welcomed. So just a few other things. We're reviewing the governance and monitoring of the group. So we're reviewing the membership of the steering group to make sure we've got that right. And the steering group will take a much more robust approach in monitoring the forward plans that I've just described and the delivering against those. We'll be looking at the area profile data, and we'll also be able to, and we're also, the governance of that will feed into the Health Protection Board, and also back into the CCG as well where appropriate. So just to describe the kind of way of working, so our single plan around vaccine confidence, and the governance being the steering group, the Health Protection Board and the Mass Vaccination Programme, and our planned approach is a plan, do, review and understand approach on a 4-week cycle, to enable us to join up all the elements that we need to do from the engagement right the way through to when people actually get a vaccine. So I think I'll just stop there and unshare my screen if I can and ask for questions.
Thanks. Have we any questions? No, I've written down understand, plan, do and review. That's your key points. Okay. I think Councillor Howitt.
Thanks. The only thing I'd want to just say is obviously the spring booster programme has just started, and I'm sure everyone's pulling together to make it effective, but we've got a responsibility to ask questions about that and to see that it's happening. So perhaps we should hear a little bit about that now, and also just ask our officers to keep in touch with us about the progress of that programme and that it's hitting its targets.
Good.
So I, unfortunately, unfortunately, yeah, I can't update you on the spring booster program. Maybe Jan will be able to. I'm specifically in the confidence area.
Thank you, Jan, if that's okay.
So, so I think it's too early to say. So we have, just to give people context, we have more sites to vaccinate from than we've ever had before available. We have a way to ask people to come for their vaccine, for their spring booster. We've also got ways that we can proactively call individual people if they haven't taken it up, and we're pretty confident that we've got enough capacity to do that. I think what I can't comment on because it's week one is, and are people taking it up? And I think it's going to be a real key marker, actually. And close on the tails of that, we are asking some questions about health and social care workers as well, and how quickly they get done. And we understand that is going to follow. So everything is in place in a very organised way. And I have to say the difference with the spring programme is we had some notice, which actually makes a big difference to making sure that we've got the plan in. So as I said, more sites than ever, really clear way, really easy to book, but it's too early to say whether that means people are taking it up. What I will say is we shouldn't forget that depending on how you look at our population number, we still have shy of 20% of people, again, depending on how you look at the population number, that haven't had any vaccines. Every time then we do a round from first to second, second to first, we lose percentage uptake in all of that. You know, and as you go down the age range, that drop off gets greater. So if I look at, you know, if you get a 5% reduction of people who between vaccines who then have their next vaccine, you end up with quite a different percentage number covered by the vaccine. So I think what we've got to focus on is not just the spring programme, but actually the people who still haven't had it, and the attrition that we've had through from 1 to 2 to 2 to 3 already, and make sure we're pulling those people forward. Because I think that's my worry is that actually people will start saying, I don't need to now get the booster, because it causes less harm than it did before, and I think that's a real risk, and we're kind of seeing that.
No, thanks very much for that question and the response. Okay, do we have any other questions? Yeah, sure, Councillor Handley.
Just following up on that, Jan, if I may. Do we have clear data that shows that, you know, how the effects of vaccines diminish over time, such that, you know, if you had maybe someone gave up after having two vaccines or something, and they just I don't need it anymore, I'm okay. You know, is there good evidence that actually the effect of the vaccine wanes and they become very seriously, the possibilities are increase enormously that they can become seriously ill?
So the work is carrying on a rolling programme nationally to keep testing immunity with vaccination levels, and what we are starting to see is, or what we are working through, is that national guidance and the optimal window for then having a booster. I'm not sure, Jyoti, what the attrition is on effectiveness actually. If they've only had a first dose a year ago, actually does that give them any coverage or no coverage? I don't think, from what I've seen, the booster programme wouldn't be doing this regularly if it gave you enough protection, would be my reflection. But Jyoti, you might have something technical.
Yeah, I mean, I think waning immunity is even more pronounced in older populations, and that's why we're getting the fourth dose in the over 75s. The more doses you have, the longer the protection lasts. So if you've got one, it'll last less than two, and then having had exposure on top of vaccination gives you even further protection. I mean, this is, you know, if we compare it to colds or flus, where it's always been circulating, our immunity is built up since we were children. We're kind of condensing our immunity to it through multiple exposures and the vaccine. as a population, that is.
I mean, my question was following up what you said, Jan, about it's a real concern that people don't keep up their booster, and that's what behind my question.
And I think that's right, and I think that's why we've always focused on those that haven't ever had a vaccine, and then, as I say, that attrition rate, because that is really concerning. I think when you just see just that few percentage points falling off between, then actually, you end up with a bigger gap in the end, and it's a bit... You have to be careful with the maths, just looking at numbers of doses, and actually you have to look at who still has coverage, if I can put it that bluntly.
Okay, thank you very much. And I'm sure that's all feeds into our communications plan for the next stage. Yeah, for comms who are listening to this. Okay, if there are no other questions, then we'll move on to the last item, which is any other business. Does anyone have any other business? No. Okay. Well then, in that case, thank you all for being here today, and declare this meeting closed.